so much, Justice Bard. I really appreciated this opportunity and working, coming from the healthcare side of our mutual work together. It's a real honor to be here, and really a great opportunity for me to learn for my own practice, as well as to share the knowledge among all of us participating today. So I'm hoping this is my first time hosting such an event via Zoom. So hopefully we don't have any too many technical hiccups, but fingers crossed yesterday's sessions went really well and we have a similar experience today. So we'll get right to the chase. Our first presentation today, we're really excited to have, as Justice Bard mentioned, a topic that I think is of interest to many of us, and the impacts of cannabis on drug treatment courts. So possession of cannabis for personal use is decriminalized in Canada, as we're all well aware. Findings from a study on cannabis use by drug treatment court program participants will be discussed here by experienced drug policy practitioners and a research team with lived experience as part of this program participation. So I will introduce Candace Vena. Candace is currently, she'll be moderating this session. Candace is currently the Director of Justice Policy at the Canadian Mental Health Association, Ontario Division, and oversees the mental health and justice portfolio. Over the last 5 years, Candace has been involved in leading work in the Human Service and Justice Coordinating Committee, a network that is established to better coordinate resources for people who have complex needs and are involved in the justice system. And I will also add Sudha Sabanadesan will be participating in this. Sudha is the lead policy analyst for substance use at the Canadian Mental Health Association, Ontario. She previously worked in the public health policy at Toronto Public Health as Policy Development Officer, where she led the City of Toronto's health policy on cannabis legalization and provided leadership and implementation of the Opioid Action Plan as staff of the Drug Treatment Strategy Secretariat. And finally, Nikoleta Curcin is a research consultant with the MAP Center for Urban Health Solutions at St. Michael's Hospital, part of Unity Health in Toronto. Nikoleta graduated from the University of Toronto in 2012 with an honors in a Bachelor of Arts degree in English Literature. As a speaker and person with lived experience, she brings a unique perspective on the sources of trauma inherent in the criminal justice system and experienced by criminalized populations and advocates for therapeutic alternatives to incarceration. So I will hand it over to you, and I want to say, working in early psychosis myself, this is cannabis use and involvement in the legal system is something that's very much a hot topic. So I'm really eager to listen and learn. So over to you guys.
Thank you so much, Brian, and thank you to the organizers for having us today. And those were some great introductions, so I won't go too much further into that, but just wanted to provide some context of our respective organizations. So as you mentioned, I am the Director of Justice Policy at CMHA Ontario. CMHA Ontario is a nonprofit charitable organization, and we really are a leader in the mental health and addiction space. We work collaboratively with our various levels of partners, so at national, provincial, and local levels, and particularly work with our branches to support all of their efforts. You also mentioned the Human Services and Justice Coordinating Committee Network, which CMHA Ontario is the secretariat for. So they were a key partner in this work, particularly at the provincial level, as we have a provincial planning body who is primarily focused on supporting the provincial government strategy and identifying those provincial policy and system issues. Sudha is going to be kicking us off, and as mentioned, she is our substance use and lead at CMHA Ontario, and then Nikoleta will also be participating after that. We're so happy to have her as our research consultant and bringing her unique perspectives and lived experience of a drug treatment court. So with that, Sudha, I'm going to turn it over to you to get things started.
Thank you, Candace. Thank you so much for that introduction. Let me share some presentation slides. Right. And all right, does that look good? Perfect.
Looks great.
Thank you. Thank you. So today it is my pleasure to co-present the findings from a study that we conducted on cannabis and drug treatment code programs at CMHA and partners. And it is my pleasure to co-present with Nikoleta today. So the project we will be discussing was led in partnership with it was a partnership between the Canadian Mental Health Association Ontario and the John Howard Society of Ontario, with support from Dr. Akwasi of Subimpa and the Provincial Human Services and Justice Coordinating Committee. The John Howard Society of Ontario was the lead organization for conducting the field research, along with obviously Nikoleta, who was a big part of the research. The project had an advisory committee that provided guidance and direction in the planning and implementation of the project. The committee was comprised of several leaders in the field, including Justice Barnes, representation from provincial crowns, community-based service providers, drug treatment code staff, and other leaders in the mental health and addiction sector. It was funded by the Mental Health Commission of Canada. It was part of funding for studying cannabis and mental health. And the focus of the research, in short, was the impact of cannabis use during participation in drug treatment code programs in Ontario. Okay. So just quickly about cannabis use. Even though cannabis has been legalized, there continues to be a need to build the evidence on cannabis and impacts on mental health, especially among priority populations. Due to the fact that it was not legal to study cannabis, now we are at a deficit and we need to build the evidence. So as part of this, of course, people who are justice involved were recognized as a priority group. And it is important to learn about the services provided and the needs of this population so that we can better serve them. And due to the fact that cannabis was prohibited for 95 years, we are still evolving in terms of how we perceive cannabis use and the policies. And it's been 5 years, and yet we are still catching up to the fact that it's legal. And one of the things that prior to starting the project was the CMHA Ontario conducted a quick survey of drug treatment code programs. And we did learn that the approach taken to cannabis use by participants in the program was not unified. So, this project was conducted as this was part of the reason for carrying out this project. So there was two streams to it. So one was the impact of cannabis use during participation in drug treatment code programs, as we learned from drug treatment code clients. And of course, also we spoke to service providers to learn about perceptions of cannabis use and the resulting impact of how clients are supported. So in a nutshell, it is to understand, does cannabis use impact someone's ability to complete a drug treatment code program? And there were many other aspects that we learned. Just in the interest of time, I'm just going to focus on a few of the objectives of the project. So the project was started in late 2019, the fall of 2019, and it was completed end of last year. And it primarily had two parts to it. There was the learning from drug treatment code clients and service providers, And we also, as part of the project, there was a knowledge exchange forum and a policy workshop. So the research used a mixed methods approach to assess the perception of cannabis use in mental health. The client participants included individuals who were going through the drug treatment program who may or may not have been using cannabis during the study. This was a longitudinal study through 4 surveys between May 2021 and August 22. And all participants, the drug treatment court clients, were provided compensation for participating in the survey and or any other activity as part of the project. And the service providers, there was a one survey and interviews. So it's just I'll go through some of the results, but just to give you an idea of some of the survey questions for the DTC clients, the questions was along the themes of what are your cannabis use patterns currently and over the lifespan, what led to your participation in drug treatment codes, and then a number of other questions. And with the service providers, the interview questions asked about how they can best support clients during their participation in the DTC program. And also, does cannabis use impact someone's ability to complete a DTC program? And a number of other questions to learn about their views. In November 2022, there was a knowledge exchange forum, which was a public forum, which was really well attended. I'll go through that later a little bit, with really good conversations and ideas that came forth. And then there was a policy workshop, a focused workshop that was held towards the end of the project as well. And that was by invitation to key stakeholders. All right. Did I go too far? Okay, so I just want to, before presenting some of the results, I want to talk about the project challenges. So as I mentioned, we started in late 2019, and that was right at the start of the pandemic. So that was that one challenge. But one of the challenges which would have happened at any time is the fact that some of the DTC programs are abstinence-based. And so the teacher staff, the champions we connected with, did not recruit clients to participate in the research study because it was a requirement for clients to abstain from all substances to successfully graduate, even though they took what they consider a harm reduction approach to programming. So this was obvious limitation because there was a whole subset of clients that we could not speak with. And then the COVID pandemic related challenges was also something we had to deal with. So some DTC programs were not operating only operating services remotely or without active participants. And the staff capacity was one of the bigger issues. As you know, staff was stretched during the pandemic, serving on a number of issues, and that had an impact on recruitment and also a big impact on kind of the diversity we were looking for. We're looking for more women, Indigenous, people from Indigenous communities, Black communities, and we could not focus on that due to these challenges. So there was also, again, access to technology and literacy, people who are home, unhoused, and have no access to services were obviously not part of the study. And as a consequence of all of this, and also the fact was that we did not get regional representation. In fact, all of our clients were from the Toronto Drug Treatment Code from the Toronto Drug Treatment Code. So the findings are smaller than we intended. The sample size was smaller, and the findings are more descriptive, and will not be able to generalize it. However, it provides really good insight into the experience of drug treatment code clients and also service providers. So I'm going to go through a series of results before just a few. It was a huge report with tons of information. I'm just going to go through a few of them. Just demographically, the study participants were predominantly male, 93%, and 2/3 identified as white. The average age of participants was 44, and most fell between the ages of 36 to 55. And 80% of participants reported that their first interaction with police was when they were 25 years or younger. Many of them were much younger. And then one of the things I wanted to highlight was how did they end up in a drug treatment code program? The most common referrals to the DTC program include through a court worker, self-referral, duty counsel, and the client's lawyer. Most respondents joined the program as a result of being charged with an offense and substance use related to their current charges, and specified being in the program for about 1 to 2 years or more than 4 years. All respondents share that they felt supported by the drug treatment code and their treatment team and provided positive feedback. A few respondents shared that the drug treatment code program had saved their lives, while others detailed their satisfaction with the level of support and care that they received. So in terms of reasons for consuming cannabis, the most participants indicated that cannabis use did not impact their life. Those who reported an impact noted that it was positive on their overall well-being. However, it had a negative impact on their education and employment. And as you can see from this graph, anxiety and support helps sleep, and also just the enjoyment of consuming cannabis were some of the most frequently mentioned reasons. And this was also relaxation, stress relief, and a number of other reasons. I also wanted to just state that prior to their current conviction, for the reasons that they were in the drug treatment code program, about 46%, clients also used other substances. And among those who said they'd used other substances, 46% reported using crack, a similar amount cannabis, and also fentanyl. But these were the most common substances that clients used prior to their current conviction, which resulted in the participation in the DTC program. Trauma, grief, depression, and other mental health issues were the motivating factors provided to explain their substance use. And this slide shows some of the responses they provided as to what the types of benefits that they had by joining drug treatment programs. And as you can see, the participants felt really supported by the DTC staff and their treatment team. The benefits included social support and treatment services, and a dedicated support team, incentives, and having an individualized treatment plan. So these were unique that they felt that the drug treatment code provided for them. But of course, there were also challenges. And, you know, the challenges reported most frequently were abstaining from using substances and attending treatment programs. So the transportation challenges, and I know also for clients who are outside of the Toronto regional area, it's even more significant in terms of transportation to drug treatment court programs and requirements, and attending court regularly. So there were obviously some challenges, and these are important for us to note. And these were amplified for many by the COVID-19 pandemic. And as you know, with the lockdowns and other a reduction in services. So we did ask, have you consumed cannabis? And this was a really interesting result. As you can see, so the survey lasted for about 2 years. As you can see, like before just as the beginning of the project, 96% said they had consumed cannabis. This graph doesn't show how often, but it just says in the past 3 months. And it keeps declining at the end of the study. So over time, the frequency and amount of cannabis consumption self-reported by clients decreased from 96% to 68%. And by the end of the study, participants indicated they either did not use cannabis or consumed very small amounts. Just to be mindful, these are all self-reported. And so we just need to be aware that there might be reporting bias. And just with this, I would also like to take a moment to touch on the overall findings on mental health and sentiments expressed by DTC clients at the end of the study period. So in terms of mental health, the overall impact of cannabis use on mental health was mixed. While cannabis use as reported by clients did not worsen and may have improved mental health, anxiety and panic reactions were also reported. So the impact of cannabis on their mental health had mixed reactions there. DTC clients were more likely over time to rank both their overall health and their physical health as good or very good. So this was really an improvement we saw over time. And over the study period, clients indicated that they made positive life changes related to employment, education, social relationships, and reduction in criminal justice involvement. Now, Nikoleta will expand on all of this in her presentation or in her talk. And at this point, I am going to pass it over to Nikoleta.
Hello, thank you, Sudha.
Nikoleta, please let me know if you want to keep this slide up, or I can stop sharing and put it back
You
on.
can leave it up. I will just talk over it. So I'm going to start with a quote from Schopenhauer. He wrote, "Every man takes the limits of his own field of vision for the limits of the world." Our collective perception of cannabis has recently shifted from propaganda, prohibition, criminalization, and now to legalization, and even the study of possible benefits. Indeed, our perception of substance use in general is in flux, from blaming dealers and users to a more encompassing and compassionate view of root causes such as poverty and trauma. There is an increasing body of literature that links cannabis use to a decrease in consumption of other substances. Acting as a harm reduction tool, access to regulated cannabis can result in a reduction in the use of other substances, including opioids, alcohol, tobacco, among others. This is still an emerging area of research and one that may contribute to supporting practices that aim to minimize health and social harms related to substance use. So Sudha already told you a lot about the study. Just to repeat, some of the themes we explored include cannabis and harm reduction, cannabis in relation to trauma, in relation to mental health, psychosis, and cannabis in graduation versus successful completion of a DTC program. So we know in specialized courts, there is a lot of talk about being trauma informed, and that there is a focus on trauma in these problem-solving courts. So in relation to mental health, we know that harm reduction increases quality of life for participants. And as Sudha mentioned, there is still a lot we don't know about cannabis. Research into the plant itself has isolated THC and CBD as two of the more than 400 chemical compounds found in cannabis. We do know that cannabinoid receptors are vital for post-stress response recovery, and that cannabis use could assist people living with trauma and complex PTSD, which is prevalent among substance users and the incarcerated population, including DTCs. So how can DTCs support cannabis users? Currently, many DTCs don't actually test for cannabis use, and there seems to me to be a sort of don't ask, don't tell policy in effect. But in order to serve participants as best as possible and ascertain whether, and importantly, for whom cannabis is an effective harm reduction tool, we need additional research. And DTCs are prime candidates for data collection in the context of substance use and harm reduction. Sudha also mentioned some of the issues we had with the study. It happened during COVID, and Toronto was our sample study when it came to participants. There was social service providers that did participate in other DTCs around Ontario, but as for participants, they all came from Toronto. There is also a vast range of how DTCs approach harm reduction. Some are harm reduction based, some are abstinence based, and some combine the two. So this was also another sort of complication when it came to not being able to divulge certain information. If you are an abstinence-based court, you are functioning within that structure, and so having participants reveal potential substance use could be problematic, and so that research wasn't actually part of the study. And but I do think this would be really interesting to explore further. What best serves the population? I think we've come around to thinking of harm reduction as a better initial method that may eventually lead to abstinence. So some of the things that I think DTCs could employ in order to provide better programming for their program participants is one, flexibility. So including incentives and sanctions in addition to harm reduction practices to better achieve not only program goals, but individual results. And I know there are various points that specialized courts, drug treatment courts, I think there are 13 points that they offer, that is their goal for their participants. And of course, some of these are recidivism and lowering rates of reoffending and so on. But one of them is quality of life. And I wonder if maybe this needs to be the most important goal of treatment courts. Of course, how we define quality of life, I think we've come to some sort of societal consensus on what this means, or some of the elements of quality of life. And taking self-reporting and anecdotal responses from participants in DTCs, perhaps that they should lead our perception of what is a better quality of life to them, and then create individually relevant treatment options that are more effective at responding to the needs of participants. So I remember I might have mentioned that I am a graduate of the Toronto Drug Treatment Program. And so I remember one of the things that really helped me, and this was actually a sanction, and many of the sanctions I would, feel like, why am I being punished for something that is at that time beyond my control? Because my ability to effectively problem solve, to effectively manage my life, and to consider consequential action of my behavior was impaired. I was in active addiction, and I still had not processed trauma that I had experienced both prior to my involvement with the justice system and during my involvement in the justice system. So, but one of the effective methods was I was given a writing assignment. And of course, I'm not suggesting that this would work for everyone, but for me, the writing assignment, even though it took me a long time to complete, every time I came up with a new excuse why I didn't have it with me, but once I finally did, it gave me the opportunity to have insight into my own situation of what I want out of the program, and not just in a way of where I'm saying something that they want to hear from me, or that I think they want to hear from me, but in a real way, something that I could reflect on my own, and then if I wanted to later discuss with the team. So that was a sanction that was very beneficial to me personally. So also, I find there are some unrealistic expectations of participants when they're in active addiction. So again, I'm just stressing the importance of individually relevant treatment. Again, cannabis in the context of women with children is another issue. There is a fear of stigma, fear of CAS involvement. Now, the effects of cannabis criminalization on racialized populations and other substances as well, not just cannabis, and how can we mitigate this in specialized courts? I think one of the important things for me that stood out in the study was the difference between the age of first contact with police versus the average age of program participants. It's on average a 20-year gap. So how can we, as a justice system, as specialized courts, preempt and into getting participants at an earlier time, so that this isn't a lifetime experience for them. Also collaborating with judges, lawyers, probation officers, the Bar Association, law schools, jails, prisons, frontline organizations that work with these populations. And then one major thing we heard about was funding. So that is also something to think about. Cannabis has become a massive industry with lots of money funding in, and I was just wondering, how can some of the funding from this be harnessed to benefit individuals who had been most affected by criminalization of cannabis prior to legalization? So we talk a lot about trauma-informed programming in specialized courts, yet we often fail to see our systems, including the legal system and other authorities, how they process and shape public behavior. The court system has at large not caught up with social reforms that have and are still taking place outside of the criminal justice system. We seem to miss the unintentional irony between systemic claims of rehabilitation while actually enforcing trauma through punishment in an already vulnerable population. And this we have called justice. DTCs aim to provide compassionate treatment and separate themselves from the Kafkaesque elements of the criminal system. And so a philosophical shift is necessary in our perception of justice, not only in specialized courts, but our societies at large. So I'll leave you now with a quote from Nietzsche, who wrote, "All things are subject to interpretation. Whichever interpretation prevails at a given time is a function of power and not truth." We should more often examine whether our systems are being built on evidence to the benefit of all its citizens, or whether they are simply a function and extension of power for those who wield it. Thank you so much.
Thank you so much, both of you. That was a fantastic.
Brian,
Yeah.
sorry, I just have a couple of more items to share, if I may.
Yeah, we've got 5 minutes. So
Okay,
yeah.
okay. I just want to make sure. Okay, why is this not advancing? Okay, here we go. So just quickly, I wanted to share that we heard from service providers, and in general, they were supportive of, or I should say, understanding of cannabis use in DTC programs, but were also concerned about the long-term impact. And identified supportive housing, programming, and dealing with complex clients as priority issues. The other thing, sorry, having trouble advancing this. Oh, okay. I mentioned about the policy workshop and the knowledge exchange forum, and we had diverse views from questioning the need for drug treatment programs within the context of criminalizing substance use, and also how to improve the whole range. And so there were a number of themes that were identified, mostly looking at how to improve drug treatment codes and taking a more harm reduction approach, providing more individualized analysis, and also ensuring that marginalized people, people in the Indigenous, Black, and racialized community are also well represented in drug treatment code programs and removing barriers. So in the interest of time, I'm just going to just share that there were a number of people in the project team, share the names, and thank you very much. Candace, over to you.
Thank you. Thanks, Sudha and Nikoleta, for that wonderful presentation. And Nikoleta, I really appreciate every time I hear you speaking and sharing your experience. It really is amazing. And leaves us lots to think about. I know we only have 2 minutes here, Brian, before we have to move on, but I'm here to moderate any questions that folks have. One actually did come through during the presentation, just asking if they would be able to get a copy of our report. So the report that we completed for the Mental Health Commission of Canada was very long and technical in nature. However, we as a team are working to kind of adapt a longer report into something that would be more public facing and helpful and easily digestible in terms of our next steps and some of the policy recommendations. So we're happy to keep folks in the loop. We will be doing that through the HSJCC network and mailing list, as well as our CMHA Ontario channels. So please stay tuned for that. But any other questions, please feel free to throw them in the Q&A now.
Maybe I could just pose one super quickly. Nikoleta, I really appreciated the comment you made around that gap of 20 years that we're seeing people being, and I wonder just if anyone was willing to comment on, in our line of work, what we really aim to strive for is reducing a DUP, so that the duration of untreated psychosis, so people get access as soon as possible. And I wonder if you guys had any thoughts about ways that we can better support reducing that gap.
Briefly, from more personal experience as opposed to research. So my first contact with police, I believe, was at 16, which is actually when I started, I guess, having mental health problems, though they were either undiagnosed or misdiagnosed. And it's only, really 20 years later that actually there was a diagnosis that actually made me feel like, oh, okay, this explains a lot. But so in between that time, I guess mental illness led me to experience a lot of things that I might not have otherwise. So relationships that were abusive, a variety of trauma. And in that time, a lot of contact with the justice system, not just as someone who had committed a crime, but also because of, or mostly at first, because of my experience with intimate partner violence. And while I was with him for the 4 years, there was a lot of useless police interaction where I was not advised of any resources. I had no idea that resources for IPV existed at all until the relationship was done. And so, yeah, just I think therapists, psychiatrists, youth, I think is probably the best time to catch that, because a lot of the people in the study mentioned they were 17 at first contacts. They were teenagers, they were young offenders. So at that point, I think is the most important part, where we need to create a circle of support for the individuals who may or may not have mental health problems, who may have traumatic backgrounds and a variety of issues. So yeah, thank you.
Yeah, I'll just add to that as well, Nikoleta. I couldn't agree more. I feel like there are so many folks at different contact points of the justice system that we are somewhat missing, and that's, dependent on whether they have a diagnosis or not. But it's about that collaboration and really bridging the gap between the human services and justice sectors. We know by virtue of police's role that they're the first often point of contact for folks who may have mental health, substance use, or other kind of complex needs. So how can we support them in getting folks connected to the supports they need, and really considering the broader social determinants of health? So having access to housing, employment, all those things that need to be taken care of first, so that someone can be stabilized and receive the supports they need, and hopefully get them away from the criminal justice system and more to a health focused and holistic approach.
Do I have time to very briefly add something? I also think that education is a massive piece, and like how we socialize children in our society, I think matters so much. So teaching skills of emotional regulation and all those other aspects that, we learn in drug treatment court when we're already much older and have had a lot of traumatic experiences. I think even when somebody might, as a teenager, develop mental health problems, having that background that becomes part of like our society is going to be a very vital factor in shifting our perception of justice and criminalization. Thank you.
Wonderful. Well, thank you so much, Candace, Sudha, and Nikoleta. Nikoleta, especially as someone with lived experience, I think your perspective is really, really well. We really appreciate the courage in coming out and speaking, and I think your voice is one of many that I think we're happy to integrate that knowledge. So thank you so much. And again, information around the study and contact information, I believe, is in your bulletin. So I'm assuming people can reach out if they have any questions. And just want to draw attention, Robin left a really nice comment in the Q&A section. So